Go. You flexing yet?
I lost everything. It's all gone. There's nothing to flex.
After less than a week.
All the gains action.
All the gains are gone already. I gotta hide my gains here, actually. From the camera. Okay.
I like the angle you're pointing at the camera. It's very...
It's questionable.
It's questionable.
Well, we're back.
It's very aggressive.
We're back, and we're back with content this time. Instead of rambles. Hey, we'll still ramble. But, sciatica. Sciatica. Also a common word. I wanted to message Brittany because we always laugh behind closed doors and not naming names. But what they write on the form for sciatica, the way that you could spell it, the way that you pronounce it, sciatica is a popular one. What's the other one? Sciatica, sciatic, like with a SCH. Like the spellings of it are so bad. Do you know how to spell it?
Hell no.
That's all right. You could spend an hour right now talking about it.
Yeah. Cool. Well, I don't even know what the hell sciatica is.
You're interviewing me about what sciatica is,
actually. I am, because I want to learn more, because is it a made-up thing?
It's a myth. Yes, just like fibromyalgia.
Is this another one of those fibro episodes?
It might be. No, because if people have really experienced sciatica, I put it up on Instagram as a poll. I put the worst as an option to click on, because that's, if you have experienced true sciatic nerve pain, it is the worst. It's debilitating. But what I want to open up with is presentation, because I think, God, if I had to put a percentage on it, 75 to 80% of people that come in and claim they have it don't actually have it. So, and that's not, it's not like my fibromyalgia rant. That is, it's just a misdiagnosis.
Misdiagnosis.
Yeah. Or
mislabeling.
You self-diagnose yourself with Google, and then...
Gosh, I love doing that.
Right. So I have pain from my hip shooting to my butt, and they go, butt pain, well, type in on Google, shooting pain into my butt, sciatica comes up. So they come in and go, I have sciatica. And I have to educate the patient, more than likely than not, that it's not true sciatica.
So what is the true symptoms of sciatica? Or how do you diagnose it so it's not mislabeled? Like, what is sciatica? Because I've heard from other PTs and stuff, it's kind of just like a catch-all.
Yeah.
Like in that general area, if you have pain kind of radiating down your backside, then that's kind of sciatic, right?
Right.
That's what most people think, I think.
It's tough because I think in a practitioner world, we can specify.
Yeah, that's what I'm asking you. But for what I've heard or what people have said, it's like, I think I have sciatica or I have sciatica. But I don't know, and I'm not there to diagnose, and I could care. It's not that I could care less, but my thing is movement. So I'm just trying to get you to move without feeling that same pain, whatever it is, or whatever you want to label it. I could care what it's labeled. I just want people to move better.
That's interesting. I think that from a general public standpoint, you have back pain, and then you get a neurological symptom from that back pain.
Okay.
So your lower back's stiff and achy, it hurts sometimes you get some sharp pain, and now you're starting to get a shooting pain into your butt, numbness tingling down your leg, or in the front of your thigh. Sometimes people mix those up as well, and it's just like, Google it, go get help for it. And that's fine with me. I'm okay with people doing like, hey, crap, is this really bad? And it goes like, neurological symptoms are bad. Yes, go get help. Should you go to a chiropractor first? Depends on the mechanism of injury. If it's just happening over time and you just, I've been lifting weights really heavy, I've been caring for my newborn kid, and I'm getting like that numbness tingling down my thigh.
Or running.
A lot.
Usually running is what, in my field, I've seen trigger that. I've been running a lot more. I've been training for a race.
Yep.
And then now I feel this. I think it's sciatica.
We can get into that easily as a big mechanism of injury.
Do you recommend that because the way that we work, when anyone messages me like, hey, I have something going on, what should I do? I always refer out, because that's not my lane. And if it is real nerve damage or something, I always go see Ian, get checked out, or go see your doctor, whatever, because I want you to get cleared, because I'm not going to give you all these exercises.
Here's the thing. If you go to your doctor, if you go to your GP first because you have a neurological pain and you're like, I'm scared of it, which it's okay. It's debilitating. I can't move. I can't stand upright. Okay, go to your GP. Your GP's going to zap you with an x-ray, tell you have disc thinning and degenerative disc disease at L4, L5, arthritis of your low back. you should go to physical therapy or get a shot or get a medication. And it's like those
or
are
stop moving, which is probably
a lot of rest gets recommended, until the complaint goes away. What I would do, especially for a chiropractor, we're considered low back doctors. We have studies that show that we are more effective for lower back pain, chronic lower back pain, way more than a GP, because we actually get you in active care like right away with treatment, right? So
and you can identify whether it's real.
Right. Like your doctor might just, like I've had patients come in and go, I'm like, did the doctor take you through some tests? And he's like, yeah, he had me like reach my toes and of course it hurt, and he had me bend backwards and it hurt. And it's like, okay. And then he just basically goes, okay, x-ray. He has no idea.
Yeah.
He's a general practitioner and it's not his job, honestly. His job is to recommend his number one form of therapy, which is physical therapy, right? Because he's like, if the physical therapist can't take care of it in 6 weeks or 6 to 8 weeks of treatment with stretches and whatever modalities they want to use in a hospital setting, then we're going to get you an MRI and then we're going to recommend a shot from that point. I have patients like that right now that are like, I'm to a point now where it's like, I need an injection, to reduce the inflammation around that nerve.
Are there, for sciatica, when it gets to the point, because that's what we're trying to do, it's like people that label it or diagnose with sciatica and then it doesn't get better from whatever they're doing, is surgery, and do they get prescribed surgery at a certain point, or is it always just PT and shots?
What I wanted to get to is it depends on your mechanism of injury, right? So if I have a patient, which I'll take you through some clientele that I've seen, if I have someone that got into a car accident, zero back pain before that, and then they have radiating pain down to their foot, numbness and tingling down the back of their thigh to their heel, we're sending that out for imaging right away. Do I think it's a bad idea to come see me first? No, because I still took them through some testing to go, oh, whoa, this is actual true sciatica where the sciatic nerve is inflamed, it's getting irritated, and it's not flowing down your leg. You got to go get imaging right away and something like that. You just got into an accident, right? Or you slipped and fell, you got hurt in deadlifting. It's like, imaging right away might not be a bad idea. But if we take you through structural tests, meaning that like a straight leg raise test is my favorite. You put someone on their back, you have them lift their leg up as high as they can. Let's say we start with the right leg, and they have sciatica going down the left leg. I'll go, okay, we'll go on your well leg first, raise it up as high as you can. And if they go all the way up to like 90 degrees and go like, I'm fine, I just have tight hamstrings, which always is usually the case, I'll go, okay, slowly lower it. Now let's go to the left leg. They go to the left leg and they barely raise it 10 to 15 degrees up, and they're like, oh, my back's killing me. I'll go, okay, do you have any pain going down your legs? No. I'll go, okay, you can force it up a little bit higher if you can, but you don't have to force it if it's painful. And they go up all the way up to 90 still and go like, it's just a tight hamstring.
Yeah.
In that first 10 to 15 degrees like that, maybe even 5 degrees, that's all SI joint right there. So they're lifting their left leg and they're just aggravating their SI joint. So if I take them all the way up higher than that and that sciatic nerve isn't lighting up, chances are your sciatic nerve structurally in the lower back is not getting affected. So we treat the SI joint instead, and we get tons of good results that way.
Yeah, because then that's what the main problem is. Because then if they're trying to target sciatica when it's misdiagnosed, that's probably not a good route to take, right? It's like you're trying to, if you just labeled it and then they didn't do all the tests, I guess, then you can see how you're chasing your tail and it's not going to get better.
Exactly, and your sciatic nerve can be aggravated when you have an SI joint sprain. And here, I'll pull up the anatomy here on actual sciatic nerve. See, it comes up sciatica nerve, and that's what's funny is like
sciatic and sciatica.
Sciatic and sciatica become interchangeable, which it really shouldn't be. It's just kind of funny. Like, it's kind of when people come in and go like, I have TMJ problems. I'm like, yes, we all have a TMJ. It's a temporomandibular joint. It's when you have dysfunction of that joint that it's actually a syndrome.
Like
but people like
I have a shoulder problem.
So
I have a shoulder.
According to this, it's like I have a sciatica nerve. And it's like, no.
It's like, don't we all have one?
I mean, one of the topics I wanted to really go over today, I wanted to start with today was the pregnancy thing, because that's the only time you actually truly see in my experience, actually see a sciatica. Because you have hormone changes happening to your body and your SI joint's so dysfunctional from the pregnancy that...
And then the amount of weight and pressure.
Yeah.
That's so real pressure on the nerve.
I'll have patients come in with like a catching when they go to take a step, numbness tingling down on their foot. I'm like, that's real sciatica right there.
Yeah.
That's real sciatic nerve pain. But yeah.
So it sounds like a lot of the misdiagnosis is the SI joint sprain.
I think so.
Stuck or...
That's my experience with it.
My thing is always just the movement and the muscles that are not firing. You know what I'm saying? Because if I were to treat someone with... I don't like to say treat, but if I'm trying to get people to move and exercise and keep them moving, then when I get them to fire certain muscles, it takes off the pressure, I guess, of the SI joint or whatever the label you want to call it, and then they can start to move better immediately. And it's like, I don't care what you want to label it. If your goal is, and you're cleared or whatever to move, your goal is to just be able to walk around without pain, go for a run, work out. And if I take you through like the squat assessment and doing the hinging and all that, usually they can move without the pain. They just have to limit it and focus on how to get there. They have to spend time figuring out and relearning how to use the inside hamstring, the obliques, and the glutes together. And then when they finally do that, that's what I do in my assessments, and then the pain is gone. But then when they move again in that same squat or hinge pattern, and they just lack the focus, or they go back to their old habits where they're using more hip flexor erectors, and it's like, oh, it hurts. But immediately after that rep that hurt, they fire the right muscles, they're able to move through full range of motion without pain. And to me, I don't care what you call it in terms of what I'm trying to do to get you to exercise and move properly, it fixes it. So that's how I apply it. That's why I don't really care for labels unless it's debilitating or something super dangerous, right?
Yeah, and that's the thing, is just a lot of people just want an actual diagnosis. They want a name for it, right? And so I tell patients, like, that's fine. I mean, if you want to call it sciatica, that's okay, but we can even change it. That's what a lot of practitioners will try to do, is that, you know, if your sciatica nerve here, I'll pull it up, spinal nerves L4 through S3, just to not get my numbers mixed up. That's basically lower lumbar spine, which is where we see a lot of our disc degeneration at, and like tailbone, right, where our glutes come and insert, right? So the nerve, you have two sciatic nerves for people that don't know, and it comes from out your lumbar spine at the bottom and goes all the way down to your heel. Okay, so if that gets affected anywhere in there, you can have problems with your knee flexion, your calf raises, like anything like that. So that's where it becomes so debilitating. But since you assess people, you know the reason why does only one sciatic nerve get affected? Why is it my left leg is the one that's numb right now, not both of them at the same time? If you're evenly wearing out at your lumbar spine, because the axial compression of your lumbar spine is going to hit the sciatic nerve, right? But why does only one side get affected?
And also, like, if it's the loading from top down, whether they're stepping, lifting, right? You have to ask the question, what's causing that to wear down quicker?
Right.
Or
and
they're like, I was
side.
Fine for, I was training for a 5K and I was fine for the first 5K I did last year or whatever. Why does it hurt now? Well, something's obviously overused or overtrained, and now it's come to the point where maybe your overdeveloped hip flexor is pulling some shit out of alignment. I don't fucking know, and I don't really care about that, because the labels to me don't mean anything. Because how is the label, when you come to me, they're like, I think it's this. They give you a fancy thing, might be some sort of inflammation thing, or it, for me, it's just movement. Because you come to me to relearn how to move in that pattern. And if you're feeling sciatic on one side or pain on one side, we're going to assess what's causing that. Because we talk about it, FixFit's not a program. For me, it's just, we're going to try to identify potential issues that are causing the pain you're feeling. And if it's a movement fault, right, as in if you're moving your body when you run, you're not using your glute on your right side, and then when we start firing your glute and you start walking and running and the pain goes away, to me, that's it. We figured out what was causing the pain to limit you from doing what you love, which is walking, running, lifting, squatting, whatever you do, surfing. Then you start moving the right way with the right muscles and the pain's gone, then that's all I need to do, right? Because I'm just teaching you exercise.
Exactly.
That's it. And it's that simple, and it doesn't have to be so, well, but it's this, but it's that. And for me, I don't, because I just like to move forward. So when I do my 90-minute assessment, I ask them all the questions, what they do, if they sit all day, if they've had pain for the whole thing, right? The whole history. But I just want to get them moving so they can tell me all the injuries that they think they have, or it's sciatica. Okay, let's see you move. it's SI joint sprain, it's a micro tear, it's whatever, ligament this.
Piriformis syndrome.
And I'm just like, okay, I'm in my head, I'm like, it doesn't matter what you're telling me, because that's not the information I'm taking. I don't tell them that I know exactly what those things are and the treatments for, but I'm going to assess the way you're moving right now, and if I could get you to move better and move without pain, that's all I'm here to do.
So let's look at it from a practitioner standpoint, right? So if that sciatic nerve is forming into, I just told you it comes from multiple spinal levels, but it forms into one nerve and goes through that piriformis, right?
Mm-hmm.
Your piriformis is a muscle underneath all your glutes that attaches to your hip. It goes from your tailbone to your hip, and it's a hip external rotator. Like you just said, if my patient or your client is sitting a lot, which we all do, we're sitting right now doing this podcast, we're sitting on our piriformis, our hips are externally rotated, that muscle's just generally tight on people. The sciatic nerve goes through that. So that's why else a lot of my pregnant patients that have a real sciatica, we can just treat just the piriformis by muscle releasing it, by digging into it, by adjusting around the hip and the lower back, and that all loosens it, and that could take care of it, right?
Yeah.
That's up to you and I to identify to them, like, this piriformis is extra tight. What's right above the piriformis? Glute med, which also stabilizes your hip, right?
Yeah.
And we take people through that. I take people through that all the time, especially with an RDL, and they're trying to go on one leg and do a hip hinge on it, and that external rotator, the glute med and piriformis are firing so much that they're falling over. It's like you have no glute max on that side, so that's on one hip. It's like there's where your imbalance is coming from. That's why your sciatic nerve's getting lit up. We can treat that and get the symptoms down. We can mobilize that SI joint and keep your symptoms down, but until you get assessed to know and understand that my glute's not firing properly
for the movement you need to use,
right?
Because I'm going to go back to the podcast with Rodman Koenig, right? And it's the same thing you're talking about. It's great that there's a lot of things out there that can get you from dysfunction to function, like all the piriformis release or whatever, and this and that, and maybe get your glutes to fire in certain drills. So then you get to be from dysfunction where things hurt to like it doesn't hurt anymore, it's not so bad. But what you and I want to do is take them from that function to optimal.
Right.
Which optimal really means just like how you want to live your life, like quality of life. You want to go back to lifting, you want to go back to dancing or whatever, Right. Go back to jiu-jitsu without that sciatic or low back pain flaring up.
So it's kind of, I could see where people get confused though. You have, like I said, numbness in your back of your heel or tingling down your leg. It's scary. You're debilitated. It's worse in the mornings. It's worse at night. You go, where do I go? Everyone's rule of thumb is I'll go see my doctor first. I'll see my doctor before I see you. It's like, okay, well, your doctor is not going to take you through anything more than a range of motion test and then try to get imaging on it, which I'm like, fine, do that. And when they tell you to do pain meds and rest, come see me when you're ready to start moving again. If they come see me and we go through the mechanism of injury, we structurally test it, and we start treating it over, a month or two, there's so many options from there of where to go. So I do like to lead, but that's just the way my practice is ran. It's like I want to lead it. Yeah. I want to go, all right, your pain's 8 out of 10 right now. You're not mobile. You're not doing anything because you're so scared of it. Go home and take an Epsom salt bath to get the blood flow down your leg. Come get adjusted a couple times a week where we work on the muscle and, adjust that structure to get loose again. But then I'm like, if you have a true sciatica, acupuncture is super helpful for it. We went over that on the episode with Brittany because she's actually needling on the nerve along the whole nerve path. She gets sciatic relief way faster than I do.
Yeah.
But I'm trying to get kickbacks going so the glutes are actually starting to try to fire again, right? So if that sciatic nerve is inflamed, that glute max isn't firing because there's nothing happening there. So I'm like stand up and neurologically kick back and fire that glute max over and over and over throughout the day. And then we work on mobilizing it with a lacrosse ball and getting a massage for it, whatever you want. So it's like, you don't have to do all of it. Some people, like I said, through diagnosis, we could just find like, it's not that bad. It's not what you think it is. You just have to do this, and then you can jump straight into working with Mark again.
Well, it's important because it sounds like what you're doing is like you're the project manager for this case, which is sciatica pain, let's say. Or what they think is sciatica pain.
Sometimes it's very complicated, and I like that.
Which is important because if you just go to the GP, then they're just there to quickly assess and then point you in a direction.
There's a formula to what they try to do.
So that's their style. Yours is more so, hey, let's figure this out regardless. So that's why for you, labeling a sciatica is okay, or just labeling SI joint sprain or whatever. But at the end of the day, if you're still managing this case, and then you're going to take this person through until we figure it out.
Right.
Because it's not like just adjustment or just do acupuncture and then you're like, that's it.
Yeah.
It's just, this, we'll try it to see if it checks off, is it piriformis? Is it the glute max not firing from kickbacks? So it's a process again. There's no one-size-fit-all protocol because everyone lives a different life. Someone might be doing, a lot of sitting for the occupation, or some people might work out 3 days in, 3 times a day.
Yep.
So then you're going to have to spend more time with these people and then try to really invest your time in the journey with them.
Here's an extreme case to kind of talk about what you just said. You see your GP and he says subject A has sciatica. They need to go to step B, which is PT, and the PT takes you through step C, D, E, F. And it's like, and if that doesn't work, we don't know. Sorry. And it's just like you have to go through these steps, right? Versus when you come see me, not to toot my own horn, but it's like I look at every single neurological complaint like this when a patient's so scared and apprehensive. I'm like, it's okay to be apprehensive right now. Like, it is a lot of pain and it is a lot of scary things that are new for you right now. It's like, let's try step 1, and if you can't even tolerate step 1, we go backwards and go
make
to
another
plan
step
Z.
1.
Yeah, make another step 1. Because here's a great example. I had a guy come in and his lower back was fused. Okay, so it's structurally fused. So if you're telling me the sciatic nerve's coming out of, L3, L4, L5, but it's all fused together. He had all 5 lumbar fused together. He was like from another country. And it was like, he was getting sciatica all the way down to his heel. And it's like real sciatica, where we lifted that leg, his hip flexor's on fire. And he's like, whoa. And I'm like, okay, so the traditional chiropractor that's just going to try to manipulate in that area 12 times to see if the sciatica will go away, you can't. So now I just took away your manipulation tool. You better have something else in your toolbox because I can't manipulate, right? I adjusted his SI joints with a drop table, so there was no twisting or nothing like that. I did Graston on his erectors, and like we were talking about last week, all that fascia that kind of blends into your erectors from your lats, breaking all that down, and you could just hear it, and he was inflamed, and I was like, go home, take an Epsom salt bath. I recommended acupuncture right away, which he chose not to do. And then I gave him kickbacks, and he couldn't even fire his glutes at all, day 1. Over like the next month of just that, he was like back to swimming, back to weightlifting, and then when he was weightlifting, he was doing lat pull downs, and he said that's what really changed the guard for him, was lat pull downs with his glutes on. So he would sit down and squeeze his glutes, so his external rotators were on, and he would do a lat pull down. What he didn't know he was doing was that lat fascia that's blending into that SI joint lumbar erector area, he was strengthening in there. Yeah. No matter what weight he had. Then he was doing pull-ups too, I think he eventually got to. 0 sciatica after that. No sciatic, no leg pain, no back pain, because he never really had back pain in the beginning. He just had just leg pain.
Yeah, and it radiated.
So to me, I thought that was a great case because it was a testimonial to what we're trying to do. If I'm the spine guy.
Yeah, because the traditional, like you mentioned, just to recap a little, if they missed it, it's like traditional treatments, like, okay, I'm going to sign you up for 12 adjustments.
That would be, yeah.
And and from your field, like, that's not going to do anything.
No.
That's not going to do anything, and it's kind of the same thing with, like, the dysfunction of function. If you go through the PT sessions or something, they'll try all these exercises for you, and even a regular trainer, it's like, oh, if you have this, we're going to try to strengthen your glutes. We'll do mini band side steps. We'll do glute bridges. But if the intent is not there, someone can listen and go, okay, I have sciatica. Let's go do a bunch of lat pull downs. And that's still not the idea.
Right.
The idea is we
progressed him to that.
Exactly. You have to figure out exactly what's causing it.
I had a young CIF athlete this year, like training for state. Sciatica-like symptoms. It was just kind of glute pain coming from the SI joint. And trainer says, do glute bridges. Glutes weren't on. So she did all of her glute bridges with her lower back.
Yeah.
Made it worse.
Yeah, I see a lot of that.
You missed assessment. Of the range of motion. Is
the fucking barbell hip thrust, glute bridge, that pisses me off.
Yeah.
Because it's so difficult in the last 3.5 years. I don't even know how long we've been on this journey, right? But trying to get people to fire their glutes, to extend their hip, to fire with the inside hamstring, right, with their obliques, has been a fucking challenge, and we're standing there without weight or holding onto a post to make it supported, and yet people are just doing it for heavy reps. Like you look online, it's like, oh, do more glute bridges for your lower back. And they have the barbell and they have the little pad on it, and their back's up against a bench, so they do a glute bridge with 100, 200, 300 pounds, and it's all lower back. Their glutes aren't on. So every time they thrust that bar up, they're doing a glute bridge. They're using their quads, their hip flexors, their lower back.
See, that's why.
Either way, they're not using the right part of the glute.
This is why, no matter what, with that kickback, whether it's working for them or not, at least they're firing the correct muscle for when they're walking with a stride or getting out of bed and stuff. It's like, at least it's on a little bit.
Well, the thing about the drills that we both kind of prescribe, right, for the kickback, because I've seen you do it, we made a video and stuff, I like to call these things like controlled tests. So let's not call it programming, maybe.
Yeah.
It's controlled tests, because when you do it, we've done it in tandem. We work with people together, where we met at the gym and we're doing like a Chiro/FixFit assessment, you know? So having someone do a kickback standing, a lot of times like, oh, I feel it in my lower back. We're like, good. You're still not using the glutes. But it's safe. You're not doing a 200-pound hip thrust with the barbell. And the goal wasn't to program you kickbacks just for the fuck of it, to do like 10 sets of 10.
Right.
But you and I were standing there like, do a kickback. Okay, angle your hip in this way because you're going to the outside. You're using quad and outside hammy, whatever. Lower back still. And then we work with them to make sure that they do it right. And when they do it right, they're shaking, they're burning, and then they're able to do that movement pattern, which is your leg is behind you like you're walking or running, without pain.
I'll use kickbacks as a diagnostic tool. Day one, I'll stand up and go, fire, squeeze your butt together and kick back with this right leg. And if they go, oh, that feels fine, I'll go, okay, let's go to that sciatica side, the bad side, the left side. And they go to do a kickback and they're like, I don't feel anything. I just feel my lower back lighting up. It's like, exactly. So you don't load this glute on the left side, you load your lower back. Does that make sense? So like if they go to fire that left glute, their lower back takes over. They go to fire the right glute, it's easy to do it because that one's compensating. It's doing all the work.
And that's where it's, to me, like you diagnostic tool, control test, whatever you want to label it, but that is the goal of these drills, is to show them that, I always said, and I've said before, that pain is your best coach for movement. Because when you move that way, like you just used the example of a kickback, once they kick back on their good side, there's no pain. Kick back on their bad side, it's all lower back. You're like, what the hell just happened, right? If no matter what I try to get them to do and nothing helps and it doesn't get better, then yeah, maybe there is true sciatica. But again, it's, for me, it's so rare that I haven't gotten people to move, because at the end of the day, you still have to move, right? Like walking.
Yeah.
So we're just trying to get them to fire the glute to get them to walk again.
Right.
And again, it's a controlled test where I tell people it's okay to feel the pain. I think that's the difference where you and I, our approach. People will do something and they get so scared of that pain that they don't want to do shit. Because then traditionally they'll tell you take 6 to 8 weeks off, whatever. I don't know what the prescription is, but usually stop doing that. Oh, I went on a hike and my sciatic flared up. I went on a run. The first thing they'll tell you, first you need to stop doing that.
You let the nerve calm down.
And my thing is, I need you to move right away.
Well, let's get into why your movement is different than rest, because you just named two movements where we see a lot of sciatica, hiking and running. And the reason is because we've just talked a lot about the back. Okay, I talked about releasing the erectors and releasing glute med and piriformis and getting glute max to fire. Cool. The front. Okay, so if you look at the front of the lumbar spine, L1 through 5, you have a hip flexor, your psoas, going from that front of that lumbar spine down to the front of your hip. So we're talking about the back of the hip, right, where the glute's at earlier. But if you look at the front of the hip, that's your hip flexor, your psoas muscle, your primary hip flexor. It's more of a low back stabilizer, but what happens when you have a true sciatic or low back injury, that muscle spasms. And it usually will spasm on one side to compensate for where that's at.
It's overloaded.
It's overloaded.
That little ass muscle, you look it up go Google it, psoas.
Psoas, yeah.
They label it as a hip flexor.
PSOAS for people listening in.
Typing it S-O-A-S?
Psoas. No.
Psoas.
PSOAS. It's called psoas. It's also called your hip flexor which is interesting because the action of the psoas is actually to stabilize your lumbar spine. It's anti-flexion of your low back. But what it does is we sit so much and feed it all the time at work. We feed it all the time that we're sitting. When you go for a run or you go for a hike and you're supposed to be firing your glute, you're firing that hip flexor again as your hip hikes up, and it pulls on your lower back and can aggravate the sciatic nerve.
Well, let me see if I could try to not use all the big terms. So you have all these big muscles in your fucking leg and hip, right?
Tons.
So when you're running, walking, those are the two exercises we're talking about, you should be using the big muscles to drive your whole body weight.
Yes.
It's not your body. You think is fucking designed to use that little psoas muscle to run a half marathon to run
from your spine to your hip.
Yeah,
you know, it's like that's
hip
not good.
flexor. So you want to bend at the hip. You want that little psoas muscle. You think that's designed to pick up your heavy ass leg to keep your body from bending or flexing. It doesn't make any sense. And same with the erectors in your back. The
100%.
issue is that people have learned, and I have as well, from textbooks written long ass time ago, the actions of the muscles, right? Like
it's a hip flexor, so stretch it.
Or do more hip flexory things with it.
Yeah.
Don't do shit with it because it's not designed to do that. It's actually there to stabilize. Same with your erectors, right? And then the lats, right? People want to do heavy ass rows and, but again, what I'm realizing now, I just went over this in class, it's like the erectors, those muscles going up and down your back, they're meant to like resist your back from bending, extending, or flexing, right? So bending over, extending when you're lifting.
Mm-hmm.
But again, those are small ass muscles. The erectors are not that big.
This is exactly tying into what you just said earlier about a GP tells you to stop moving, which is if you stop moving, those little muscles are still on and taking over and causing you pain and inflammation.
That's why rolling out doesn't do anything or stretching doesn't do anything to fix the pain because your erectors are inflamed, your lower back is tight, maybe
psoas is spasming.
Psoas is spasming. That's what's causing all the pain.
Mm-hmm.
And the lats, the reason why doing the lats for that guy probably helped, right, your client, is because the lats, if you look at it compared to your erectors, the lats are fucking massive. They're the wings or whatever. No one has them, right?
Those are off, right?
Those are off, but those are the real muscles that are supposed to hold your back up to bend to avoid your back from over bending or extending. Yep. But the erectors are the only ones doing the damn job, versus like the big structural columns, which are your lats, are supposed to do that. So why movement works is because if your erectors are fucking blown up or seizing or inflamed from a bad squat, a bad deadlift, running, sitting all day, you get your lats to fucking turn on because they're the giant muscles in your back that do the same thing. They're like buddies. The lats and the erectors are buddies. They do the same job.
Yep.
But they don't have enough power. It's like the erectors are doing all the work. So you turn on those big ass lats, then all of a sudden the pain goes away because your erectors aren't seized up anymore.
Well said.
So therefore your psoas example, that little last muscle in the front, right? You want to get your VMO to fire, your inside hammy to fire when you walk, when you squat, and then
glute max,
your oblique, your glute max, and then when we get those things to fire, guess what the psoas does? It's like, fuck yeah, I don't have to do everything.
Yes. Perfectly said.
So therefore you can do your 90-90 stretch, which we've done a ton, roll out. There's all this fucking
tight hips.
psoas tools right now.
Yeah.
It's been promoted on big name people. I don't want to call them out because I hate
Joe
dogging.
Rogan. And the so right. Yeah. Digging in your hip flexor feels so great.
Again, if you use that for recovery, because your psoas will get worked, right? Because you're doing shit, running, lifting, squatting, walking. Great, but to fix low back pain and label it as that will fix it, it doesn't make, it's not, it's common sense.
This is the problem with mobility tools and gimmicky products like that. Just like you said, if Joe Rogan's telling people, use the so right on your tight hip flexor,
it'll fix low back pain.
It'll fix your low back pain. You're talking to high level athletes like UFC fighters that they are using their glutes and obliques and hamstrings a lot.
That's fair.
They're not sitting at a computer all day where it's shut off and digging it out with a $15 so right thing from Instagram. Like, why isn't this thing fixing it? It hurts like hell. It feels good temporarily. It's like, because you're still moving imbalanced. You're not using the glute max. You're just temporarily shutting off the tinier muscle, right? So real quick, the psoas attaches to the front of the hip. Your glute attaches to the back of the hip. When I give a kickback, it's to feed that glute max more so that psoas shuts off more, just like you were saying. I mean, they're it's both working about that hip. One flexing, one extending. Psoas flexing, glute extending. Feed the glute max more. What I was trying to get to earlier is that when people have a true, issue and pain down their thigh, let's say, and I'm like, no, you can go see Mark, because Mark can still teach you how to just fire your obliques, which takes pressure off the psoas, fire your VMO, fire your inside hamstring, inside quad properly without the pain, right? And that's exactly what you're talking about. It's just firing those bigger muscles.
That's all I do.
In a safe plane.
That's all I do, because movement is driven by your muscles. Muscles is what causes your pain, because muscles pull on the joints and stuff. So if you have an inflamed psoas or inflamed erector or whatever, that causes low back pain, hip pain, right?
Yep.
So then you have to think about it. It's like, okay, if that's inflamed, that means it's overworked or strained or torn, whatever. Then what are you going to do? Fucking aggravate it more by jamming a lacrosse ball in it?
Stretching it more?
It's guarded for a reason. This is what I tell people in my classes. Let's say your psoas, it's strained, it's inflamed, it's angry. But the reason why it's tightened up in a ball where people like to push into knots because it feels good, it's tightened up to protect something. And it's tightened up because it's a protective mechanism, so something that doesn't snap off, right? But pushing into it is going against the grain. That's not going to tell it to release. I mean, it might feel a little better, but that's why most people, when they have some sort of pain like that and they'll dig into it, they get that temporary relief because it shuts it off. But right when you go to move, like take a step, it tightens right back up. Yeah. Because your body's like, fuck no, don't rip off the joint. So the only way to get that to release is your body has to fire other muscles, and then that sends that signal to that psoas to be like, calm, you're good now. We got backup, homie. We got glutes, we got VMO, we got inside hammy. And then that's what I do, is I get them to fire that, and immediately they feel better. Because so many times people have come in with back things, and whether you referred them or they're in the gym, whatever they did, and then I get them to walk with the sled behind them. So there's a little drag sled. It's like a belt, and you just walk forward, but it's not a traditional walk. We're bracing obliques, firing the hams, all the right muscles we talked about. And then that's what gets their lower back to release.
Right.
Not one stretch, but I have to get them to start moving right away, because the longer you delay, your body's going to compensate, and people don't understand that. So if you blow out your psoas or your erectors, your back hurts. Let's say your back is fucked up and you think it's sciatica. If you just don't do any movement exercise-wise and you try to just roll out, guess what happens when you wake up the next day, when you start trying to walk or go to work or sitting? You're probably going to walk fucked up. You're going to sit fucked up to alleviate the pain.
Yep.
And then you're probably going to, whatever you're trying to do, you're going to do it. So now you just created this weird fucked up structure that it's going to take so much time to unfuck. For it, if someone, nowadays, you'll see it in our gym, and if someone just has like a tension in their back from deadlifts that we haven't even seen. Let's say if someone did tweak it, we'll get them to do oblique openers, to walk with the sled, to do sandbag squats right away, even though they just tweaked it. Mm-hmm. And I don't even have to tell them to do that. That's what just people just do, because they know that works.
Unglues it.
It unglues it because other muscles you strain your lower back because you went too heavy or you went too fast. Yeah. Great, your erector blew up. So then that's the cause of it. How do we fix it?
Neurologically rewire it, which could take, I tell my patients, that could take 7 to 10 days. If I tell you that glute max is off because the sciatic nerve is so inflamed, and they do a kickback and they're like, I kind of feel it. I'm like, check back with me in like 2 to 3 days. And it's like a little better. Check back with me 2 to 3 days after that. It's a little better. Like, it could take 7 to 10 for your body to just go, I'm walking up this hill right now. I need my glute max on. Let me squeeze it. It's like, it might take about a week just for that structurally, from your brain to that muscle to actually fire. It might take that long if there's really, really significant injury.
And how long have you let it sit there?
Yeah, exactly.
Because if that thing's been stuck and you've compensated for 6 months not doing shit, and then you come in to get, assessed by you or assessed by me, and they're like, I can't get this to fire, it still hurts. Well, then you've lived with this inflamed psoas and did nothing for it, and you took 3 months off of moving. It's like, we have to relearn how to just walk or stand even. I work with people with knee pain, and it's like, it hurts when I stand. And I have to teach them how to stand again, because standing, you're still using muscles. Right. And that's what they understand. And then it's like, then it's on them to practice or to take the knowledge to utilize it,
What we should kind of go over too is that this isn't, FixFit and seeing your chiropractor isn't exactly always going to be the fix either. I've had patients where
it's not supposed to fix you.
Well,
for you, it's different. I think the general message is that the FixFit is we're sharing knowledge.
Sure.
We can agree with that, right? We're sharing knowledge. If something hurts, we're just trying to give them what we've learned and help them self-assess if it's muscle or this. Pretty much asking the question, what's causing it? That's as simple as that. And then from there, we can help direct them faster and give them drills and whatnot. But really, we're just trying to answer that question for them, what's causing it? Versus going, take an X-ray, MRI, take a shot. Is the pain gone? Is the pain gone? Is the pain gone? That's not answering the question. That's not helping them. They're not learning anything about the process.
But each case is so different. So the key always in this is going to be assessment, right? So like, I've had plenty of patients in the past. I've had a couple I can name off the top of my head or think of off the top of my head where it's like, we assess, and I said, I think I can help. And 2 weeks in, I've been like, this is getting a little worse. You got to go get an opinion. And it's like, oh, whoa, there's a giant disc bulge there. And it's like, well, yeah, we're no MRI machine. We tried, you let it go way too long if there was no mechanism injury recently, right? Like it was like, oh, there's no acute injury. It just got bad recently. So it's like, go see your chiropractor, go see your PT or whatever. And it's like, you could still try something for a week or two, but if it's like getting worse even that quickly, you're like, dude, we got to go get, the X-ray eyes on it and the MRI imaging. And it's like, there could be underlying issues for sure in there, but it still doesn't hurt to try something conservative first and not jump straight to something like surgery right away. I have no problem with that, especially if you're able to move. We're trying to tell you how to move correctly, because I've had people too go, I Googled sciatica, and I saw 2 sciatic stretches, and same thing like you were just saying, if that sciatic nerve's lit up and you lay on the ground, put your leg over your knee, bring it up and stretch your glute and stretch your piriformis, and it lights up the nerve more. It's like, you're stretching your sciatic nerve more. It's already inflamed. Like, you don't want to just go through plan A, B, C that you find online or your PT gave you a packet. You have to, every case is so different, and everybody has such different wear and tear from different sports and different lifestyles. You have to get a thorough history and a very good structural assessment before jumping right into these things. But I would say from the FixFit mentality, there is a couple things that they can try, like an oblique opener, a kickback, walking with a sled first. Because if you're able to move, you're able to move correctly. And that's where we've seen success with people, is like, you can try a few things first to see if it can temporarily get you moving properly, because if it does, then you just keep building on top of that.
And I agree, because it's assessment. Mm-hmm. But that's now learning how to do self-assessment. Mm-hmm. Right? And it's not, again, we're not, like you said, we're not MRI machines, and neither are they, but
don't freak yourself out by going, oh, I might have a disc bulge, I might have a tumor in my spine. It's like, you don't have to get that crazy. But let's have you talk to somebody, Mark, that's listening. I know a listener that messaged me earlier and said, I've been dealing with sciatica. What do I do? Okay, and it's like, chances are, if you're not specifically telling me, I got hit in football in the back and I've had sciatica since, I got into a car accident at this age and I've been dealing with sciatica since, chances are it's just wear and tear over time of sitting, moving improperly. Let's say someone just messages you and says,
I can't get to you. Assessment?
Yeah, like, I want to come in for an assessment, but hey, I can't get to you for like a month. What are 3 movements I can do to try to alleviate or try to just at least feel some change in my movement patterns?
Well, again, the first thing, I always make sure it's cleared, right? Make sure you're good to go, you're cleared for exercise or movement or whatnot. Or I can just do a movement assessment if they don't think it's that bad. And the first thing I ask them is, like, what's your goal? Because they come in like debilitated, like, oh, it's like, fix me, I can't move, I'm hurting.
Yeah, let's say my goal is get rid of the pain.
And then I have to say, for what? Like, I understand your pain, you want the pain to be gone, and it might just be like, okay, because when I work, I can't even work. I sit all day.
I sit all day, and it just gets
like
worse.
Great. Or I like sitting's fine at work, but I like to go hiking, and I can't hike anymore.
I try to go to the gym. I can't go to LA Fitness anymore.
The reason I have to ask those questions is because I'm directing them to their goal.
Yeah.
Because I can give them exercises that may help, that we've seen in the past, that might alleviate it. But if there's no intent behind it, I give them, let's say, oblique opener, pistons, Terry's carries, whatever, like the drills I made up, and then their pain is gone. Then they go back sitting like shit at work, walking like shit because that's what they do 5 times a day. I don't know. Then their sciatica pain is gonna come back. See what I'm saying? That's my process. It's like, unless you apply it to movement, the drills don't mean jack shit.
Right.
That's why I don't, the whole thing with going from functional to optimal, that's the difference in I think what I do with PT compared to PT stuff.
Sure.
So if you came to sciatic pain, I assess you, and then your goal is to go back to, let's say, powerlifting, whatever. Then I'll assess your movements and then get you to move in those same patterns without pain. Then I can just prove to you, because your sport was powerlifting, this sciatica thing didn't just magically appear. It's the way you've been squatting, deadlifting, and maybe even benching that caused it. But now I can get you to squat, bench, and deadlift, and you did all 3 of those movement patterns without pain. Then you know it's a muscle imbalance.
Sure.
So now you have hope, you have something to work towards, and you have something to practice because you're already going to do it. So if I didn't go through that process to get you to fire those muscles, I'm going to do a piston, and then I'm going to apply it to the way you squat, because that's what you do.
So why a piston?
The piston is going to start to, we ran a little like pistons seminar. It just was unintentional. We had 5 people that were in my new FixFit injuries class, because this isn't even like a program where you're pulling sleds. It's like, whatever, if you're hurting, come on in, we'll see if we can identify what's causing it. So we ran a piston because everyone was low back or knee or something around the same issues. And then we realized it's like, even though you're doing a piston, there's different ways to help each individual. So if you and I both did a piston squat, you might feel it all in your quad, I might feel it all in my hamstring. But that means those muscles are already overused. So we use the piston drill to now, for you, if you only feel your quads, we're going to try to get the glute and the hamstring to kick on.
So explain to people what is a piston.
A piston it's evolved a lot, but let's just say you're holding an air squat, and you're going to hold it ideally at parallel, halfway down. Some people might have to go higher because everything's already shut off.
Right.
And you're holding that type of squat, and we're just starting to, let's say, run a diagnostic on you to be like, okay, you're holding this squat, which is a full body movement.
Where do you feel it?
Where do you feel it first and foremost? And everyone always points to their quads, or they have really tight hamstrings, tight hips, lower back even. Mm-hmm. And I was like, cool, that's not bad. That's just the way
they think they're low and their ass is sticking straight in the air. They're like, whoops.
I'm like, great. That's your baseline.
Yep.
You have to have a starting point to know that there's changes.
Mm-hmm. And
then get them stand up, hold that squat again, and then can you turn on your obliques? Then that's it. It's like one piece at a time. It's like that Christmas lights thing.
Notice you started with obliques, just because I would have said oblique opener first, but that's
obliques within the squat pattern. You know, so what the process is, I get you to hold that parallel squat, and you can't turn your obliques on with pushing your hands in and fingers in. Then I would use a drill to now get you, so you'll lay down, do the oblique openers. Now come back to the squat.
Your obliques are your side abs, so you're just trying to breathe.
And it doesn't make sense to do drills first, because if you did the piston squat and then I was like, fire your obliques, fire it like this, and you fired it like that, what's the point of sitting there spending 20 minutes doing oblique openers? Yeah. And then we go down to, okay, do you feel your inside hammy zone with your obliques? Then we go, do you feel your VMO? Do you feel the glute max? And then once you get all of those things to fire, then it goes, do you feel more or less on one side? See what I'm saying? And then that's where we start to build a little.
So then you put them on one leg.
Then we put them on one leg only when we found something. Okay. So then that's when we do a single leg piston, because I was like, okay, Ian, your right glute doesn't work, so we're going to do a right glute piston for you. Pump it, get it to fire. Might take 10 minutes, might take 20 minutes, it might take 5 reps. Yeah. Then once you feel that sensation, then we go back to that piston squat. You hold it down there, and then you get it to fire. Right. So that process, once you do it like that and you get these muscles to fire in a squat pattern, that first squat that they did where they only felt it in their quad, they had low back pain, they felt the shooting pain in their knee or something, it's magically gone. Right. And the analogy I share with them, because they don't have to learn about the chains and muscles, kinetic chains or whatever, strong fit chains, it's just like the weight of your body was your psoas or your lower back, whatever, your knee was taking all of that weight. Right. Because the first time you squat, you only felt one muscle, like the quad. But now, once we got everything to fire and everything's burning, the weight of your body or your barbell, or when you're running, the weight of your body going up and down, now supported through all those muscles, that pain goes away because all the muscles are pitching in.
Right.
And that one little muscle isn't inflamed because it's not doing all the work.
I could take it from a rehab standpoint too, in terms of getting pain down. If we're working on breaking down a piriformis, breaking down a glute med to get the glute max to fire better, what we have seen is that, like you said, if I do a squat test first and they just feel nothing in their obliques, I'll lay them down and do an oblique opener. To supplement that, I can show somebody that isn't active at the gym an oblique opener for even pain relief. Because when your obliques are your side abs, right? Like you explained before. Yeah. Breath in through your nose, you exhale out through your mouth, and if you press out into those obliques, your lumbar spine decompresses.
Your lower abs will kick on too if people are, if you care, but
lower abs kick on if you're laying on your back essentially, right? And your feet are planted on the ground. Your feet are planted for a reason, so your hips are flexed. That takes your psoas out of it. I start people like that are in a lot of pain. Let's say I'm seeing someone 8 out of 10, 9 out of 10 pain and it's numbness down their leg. I feel comfortable showing them that oblique opener because chances are it's off, and having them just breathe in through your nose, out through your mouth. Try to get 5 to 10 reps firing and squeezing those obliques out. When your lumbar spine decompresses in that position, what did we just say was a cause earlier? Compression.
Yeah.
Right? So now you're opening up your oblique or your lumbar spine and taking pressure off that sciatic nerve. What you're trying to get to or getting to is now you need to like squeeze those obliques as you're walking up and down the stairs.
Exactly.
Getting out of bed. And I try to tell people
that's optimal, right? Quality of life.
Right. And what I try to tell people is what you've just felt with that oblique opener, you need to squeeze those when you get out of the car, twisting, when you get out of bed. Try to just be mindful, because the word right now that you have is apprehension. And apprehension is, like you said, it's guarded, careful, careful, careful. I'm saying that's fine because you're in spasm. Let's say in the first week or two, you're apprehensive, you're spasming, you have too much inflammation. We have to get that down before we jump you into a squat. What if that whole leg's numb and they can't even walk into your gym?
Yeah.
So to get that down, you can already start firing those obliques. You can already start firing the glutes on the kickback.
You walked into the office, you walked into the gym, you drove here.
We've had people with crutches because the sciatica was so bad before. And it's like, if you could just squeeze your butt together at least. And then I've had this guy with crutches come in and leave without them because he was like...
Because he could turn on muscles.
Just turn on one glute.
It's crazy. That apprehension of like, I don't want it to hurt it again. It does feel painful. So
yeah, I
get it. But, use that as your guide, And yesterday's FixFit Sundays thing that I do, I said this to the group. I was like, your core sucks because to everyone. Yeah. And then I was like, to be honest, our core sucks because of two things. One is that your core is not firing with other muscles. So I had them do a side plank to show them that, like, okay, your glute max has to work with your side plank, or with your side abs, your obliques, and then bringing a knee up, right? So that's one. So that's probably why it doesn't function. And then the second reason is that you can't breathe and activate them. Right. So we added breathing in there because a lot of people, like you said, with apprehension and they're scared.
You hold your breath. And it's okay. I tell them that's fine. Like, we're not scolding you at all.
It just doesn't take you to the next optimal level, which is applicable to movement.
Right.
Walking, hiking. You have to breathe. Come on now. Yeah. Like, if you can't keep those things on, your glute, everything firing together while you're moving, then ultimately you're training non-functional contraction or something, or non-functional movement pattern. So if you're holding your breath doing these piston drills, what's the point?
I like it. I think it makes a lot of sense. I think the goal to take out of today's episode is, think of your mechanism injury first. If it just slowly progressed on you, you're able to walk. I mean, I literally, like I said, I've had a guy come in with crutches before. It's like, if you're able to get here that ambulatory, you don't need an MRI right away. But
even if it is true sciatica, I'm asking you because I don't know. Even if it's true sciatica, right? What is the treatment plan typically? Do they shoot in like a shot or something? Because I don't think it's that severe to give you surgery, is it? Like,
So it depends on what's actually happening at the structural level. I've never seen somebody get
that bad
a quick lumbar decompression surgery because the sciatic nerve is that pinched off.
They'll try things, right? They'll try
anything. Yeah, they'll try a epidural shot into that.
But that's what I'm saying. It's like they're gonna put you on a path of trying things.
Mm-hmm.
I just believe that this is a better thing to try as one of the many things you're gonna get led to. You're gonna do shots, PT, muscle relax. I don't even know, a bunch of stuff. But it's the same thing. It's like they're still not answering the question, in my opinion, that if you have true sciatica now, right? What caused it? True. And if it's not a car accident or something acute where it's just like you tripped or something, it's like it's typically because of a muscle imbalance for an extended period of time.
I'll tell the people though that if you're in that 7 to 9 out of 10 pain though, and you're limping because that foot is that dead feeling, it's just numb, that they're not worried about anything else besides getting the pain and the nerve pain down, right?
It's true.
I'd say give it a week or two. I'd say give it a week or two of something conservative first. And if it gets worse, you definitely have to go ask for outside resources that we don't have access to.
Yeah.
But if you are able to get into an office, get into a gym, you definitely need to try these terms that we're going.
I never work with people.
In the acute phase.
Like I don't even want to work with them because it's not my lane or
and it's
scope of practice.
That's what I'm saying. The guy with crutches, I wasn't like, hey man, if you can, you barely drove here, but you should definitely go to the gym next. He would be like, you're out of your mind. I barely got out of bed to get here. So I'm like, all right, you're going home and you are resting, but I'm still like, you're up every hour doing kickbacks or at least glute squeezes, oblique openers in bed. Like you're at least doing something active because just laying there and letting the inflammation kind of go down isn't enough.
Yeah. It's most people that we are talking to is like, that's probably the 1% if you have that bad of sciatica, but everyone that has sciatica that's like, it just hurts or they're not on crutches. I mean, that's everybody else, really.
There's a lot of people
we're trying to talk to, and it's like, come on, there's so much to do.
There's so much SI joint pain into the butt where they think, into their one butt cheek that they go like, I have it.
Yeah.
And it's like, I mean, maybe the start of it, but we can put that fire out for sure in a week or two.
Yeah.
Maybe even a month tops, but it depends on your lifestyle. It depends on what you're doing throughout the day. It depends on, did you just give birth? You know, it depends on you're about to give birth. Like, all those things factor into it, but a lot of these imbalances we see in the glutes and obliques, which means your core is basically off.
Yeah.
It's not that easy. It's going to take time.
Like you mentioned, assessment's key.
Yeah.
And what I would say is, if you're going to try everything, and typically that's what happens, to be fair, it's like people are going to try everything that they think is standard care, which is fine. I'm not disregarding, don't go PT, don't go to your GP or whatever, but if you have tried everything and you still have this issue, you're clinically cleared to be like, you know, the PT's like, I've done everything for you, I don't know what the hell's going on.
Yeah.
Then please contact us or contact me, because I like that, because it's like you have kind of been failed by the system. And this is what we're trying to do, is if you go do the traditional standard care and it fixes your sciatica, great.
Yeah. Then if the stretches and the foam rolling your IT band aren't helping, we're definitely the people to see for it, because that passive just laying on a foam roller, that passive just stretching my hamstrings out, it's like, that's not enough. It's just not enough, because your core is literally shutting off.
Yeah.
And if they're waiting 4 to 6 weeks to get you to a glute bridge as the next form, or some stupid ass bird dog thing, and it's like, I don't care about that. You have to be ambulatory, right? If you're on the ground doing a bridge, if you're on the ground doing a bird dog on your quadruped position, all fours, what is that? How does that translate to you picking up your kid off the floor? How does that translate to you getting out of the car or carrying groceries? Like, and those are your main complaints. It doesn't.
Yeah.
They don't. Their PT's last step is maybe a squat, and they're still using a medicine ball for the squat, and it's like, we're never loading the spine again.
Yeah.
But that's a rant for another day, because we've almost just went into one for PTs, but F it. I think that's a good start.
Yeah, F it.
Assessment, diagnosis. I mean, again, diagnosis is a loose term, because I'll tell patients all the time, I think it's this. It's going to take 4 to 6 weeks of treatment to really come out with an accurate diagnosis, but we can call it Sciatica, if you want.
For me, I don't have to. I'm not supposed to, and I don't want to, and I never will diagnose shit.
You don't have to.
So
back hurts, leg hurts.
Yeah, and that's why
it's that simple though.
That's why when you ask me the process, I have to say for what.
Right.
If you're like, my back hurts, I'm like, for what? Walking. Okay, let's see if you can move. I'll teach you a walking exercise.
Right.
So it's not like, oh my god, you have fucking that. To me, I don't diagnose, which is amazing because everything's there's so much misdiagnosis anyways.
But I love examples of like we've seen people with really big disc bulges proven on MRI with zero pain.
Because they've done the exercises to buffer it.
They still
have the quality of life, even though they're clinically labeled as this kind of like life-ending thing.
We know someone that needs surgery because it's so big, but zero pain. And it's like I've seen people with less tiny disc bulges with 10 out of 10 pain. It's all relative, it's all different, but one guy had a strong core and one woman had no core and 3 kids. You know, it's like everybody's so different. That's why assessment's so key, and a thorough history is so key. But yeah, message us if you have questions because we love this stuff. I personally love a complicated case because it just makes
Me too.
It's just so fun to not diagnose, but just to kind of go through that history and day by day, step by step, and see the feedback. It's awesome. We get really good results with it.
Me too. I like it's complicated, but to me it's actually not complicated because when you come in, it's like the easiest thing.
Yeah.
But it's sad that it's like the system has failed people.
Yeah.
And that's where I like to do those cases because it's like they tried everything.
We love those. I've tried everything.
And then so they go from being like depressed or sad or lost hope to having hope again and training a certain
I thought I'd never lift again.
I thought I could never surf again. I thought I could never live. Or I had to get this surgery.
We love to be the case managers for it, which is perfect. Yeah. Shout out to all the PMs that we see. Mm-hmm. All right, man, we gotta go. That was a good one though. Thanks for all the sciatica complaints, guys. See ya.